Welcome back to the RTOG Smart Review GI Cancer series. Today, we're jumping into anal cancer part 2. We'll be focusing on IMRT, how we actually plan these treatments, and tackling some of those special patient groups you'll definitely encounter.
Exactly. Last time, we set the stage right. Definitive chemoradiation 5-FU and mitomycin C. That's the standard for organ preservation. Super effective stuff, but historically, well, the toxicity was rough.
Yeah, notoriously toxic, wasn't it, with the old 3D techniques?
Absolutely. Those large fields led to really severe acute toxicities, often meant treatment breaks, and, that compromises outcomes.
He was kind of like trying to use a fire hose for delicate work, maybe. Lots of collateral damage.
That's a perfect analogy, and that's where IMRT really changed the game. It's more like a precision nozzle.
Okay, so today our mission is to unpack how IMRT did that. We'll walk through planning with a case and then hit those special populations, HIV-positive patients, high-risk disease, and crucially, what to do about recurrences.
Sounds like a plan. It really has revolutionized how we approach this.
So let's dig into that IMRT revolution first. You mentioned the cost of the standard Negro protocol with 3D CRT. Can you elaborate a bit more on why those large fields were needed and what specifically drove those toxicities?
Sure. The issue was the anatomy and the lymphatic drainage. Anal cancer likes to spread, to cover the primary tumor plus a margin, plus all those pelvic and inguinal nodes.
Like the mesorectum, iliacs, obturators, inguinals. It's extensive.
Exactly. With 3D techniques, you had these big boxy fields, and those inevitably hit a lot of healthy tissue skin in the perineum, groin, loads of small bowel, rectum, pelvic bone marrow.
Right.
So you irradiate all that sensitive stuff, and boom, severe skin broke down, terrible diarrhea, proctitis, and really significant drops in blood counts because you're hitting so much marrow.
Which then leads to those treatment breaks we want to avoid.
Precisely. It wasn't just uncomfortable, it was often debilitating. Forced breaks, dose reductions, not ideal for cure rates.
Okay, that paints a clear picture of the problem. And that leads us straight to RTOG 0529. You called it the most important modern trial. Why was it so pivotal? What was it actually designed to test?
Right. RTOG 0529, it was a phase 2 study, so designed primarily to see if this new approach, IMRT, was feasible and if it could actually deliver on the promise of reducing toxicity. The specific question was, can we use IMRT to significantly lower those severe acute toxicities compared to what we saw historically with 3D CRT in RTG 98LN without messing up the cancer control?
So not a direct head-to-head for survival initially, but focus squarely on that toxicity burden.
Exactly. Could we make the treatment more tolerable while keeping those excellent cure rates? That was the critical question it aimed to answer.
And the answer was a resounding yes, right? The results were described as a home run. Tell us about those toxicity reductions. How dramatic were they?
Oh, they were dramatic. A total game changer. Let's break it down. Skin toxicity grade 3 or higher was basically halved.
Halved. From what to what?
It dropped from a staggering 49% with 3D CRT, almost half the patients getting severe skin reactions, down to just 23% with IMRT.
Wow. That alone is huge for patient quality of life. Less pain, less infection risk.
Absolutely huge. And it wasn't just the skin. GI toxicity grade 3 or higher also saw a significant drop. Went from 36% down to 21%.
So significantly less severe diarrhea, proctitis, things that really impact daily life and nutrition.
Right. Fewer hospitalizations for dehydration, better ability to complete treatment.
Yeah.
And then there was hematologic toxicity. Grade 2 or higher dropped from 85% to 73%.
Still high, but a noticeable reduction. Fewer major blood count issues, fewer delays.
Exactly. Fewer risks, better chance of getting the full treatment in on time. But here's the absolute kicker.
Let me guess the cancer control wasn't compromised.
Not one bit. That was the critical finding. All these major toxicity reductions came with no difference in cancer control. The 5-year, even 8-year rates for local regional failure, distant METs, overall survival statistically indistinguishable from the excellent results of RTOG 9A11.
So better tolerance, same great cure rates. That's the definition of a practice-changing trial.
Absolutely. It cemented dose-painted IMRT as the new technical standard of care. No question. You achieve the high doses you need, but you spare the surrounding tissues so much better. It fundamentally changed how we approach these patients.
Okay, that firmly establishes why we use IMRT. Now let's get practical. How do we actually do it? Let's walk through an IMRT planning workshop. Let's use a case, say a 48-year-old man, history of HIV, but well-controlled on heart. He presents with a T3N1 anal squamous cell carcinoma. His CD4 count is, let's say, 350. We'll come back to the HIV status later, but for planning, where do we start? Simulation setup.
Okay, good case. So simulation. Typically the patient is supine. We often use a frog leg position.
Why the frog?
It helps open up the groin, reduces skin folds there and in the perineum, makes it easier to get good dose coverage, and avoids potential skin hotspots. Then immobilization is key, usually a vac lock bag. You want that position rock solid, reproducible day after day for IMRT.
Makes sense. Any other gadgets or positioning aids,
Well,
gender-specific things?
Yeah, good point. For female patients, we often use a vaginal dilator. It helps push the posterior vaginal wall and rectum away from the high-dose area. A bit of internal PTV margin, essentially.
Spares the rectum and vagina.
Exactly. For male patients, a scrotal shelf can lift the tests out of the field. And for everyone, bladder management is crucial.
Ah, the reproducibly full bladder.
Yes. You want it comfortably full and the same fullness every day. Instructions like drinking a certain amount of water an hour before SIM and each treatment. It pushes the small bowel up and out of the pelvic field. Simple, but really effective for reducing GI tox.
Great practical tips on setup. Now, let's move to contouring. Gross tumor volume, GTV, how do we define that?
GTV is what you can see or feel. GTVP is the primary tumor itself. Use your clinical exam. MRI is great for soft tissue detail here. Sometimes PTCT helps define the extent.
And GTVN.
GTPN is any grossly involved lymph nodes you see on imaging, peak C, diagnostic CT.
Yeah.
Look for size criteria, FDG avidity. Important to correlate with how patient too, especially for inguinal nodes.
Okay, that's the visible stuff. Then we need the clinical target volume, the CTV, to cover microscopic disease. How broad is that?
Right, the CTV is comprehensive. It includes the GTVP plus a margin, usually 1 to 2 centimeters, for that microscopic spread. Critically, it includes the entire anal canal from verge up to the levator.
The whole canal.
The whole thing. And then all those at-risk nodal basins. That's the big elective volume.
Remind us of that list again. The essential nodal basins for anal cancer CTV.
You got it. It's the mesorectum, the presacral nodes, bilateral internal and external iliacs, the obturators, and the bilateral inguinals. It covers a lot of ground.
Which explains why 3D fields were so large and toxic. IMRT lets us sculpt around this complex shape much better.
Precisely. It's meticulous work, contouring, but absolutely foundational for a good IMRT plan.
Okay, targets delineated. Now, the dose painting protocol from RTOG 0529, using that simultaneous integrated boost, or SIB, can you explain how SIB works compared to older sequential boosts? And then give us the dose tiers for our T3N1 patient.
Sure, SIB is really clever. Instead of creating the big volume first, then coming back later to boost the gross disease, SIG delivers different doses to different targets every single day, all within the same treatment course.
So higher dose per fraction to the tumor, lower dose per fraction to the elective nodes, concurrently.
Exactly. The main advantages are, 1, efficiency is just one plan, one setup phase, much smoother, and 2, potentially a radiobiological plus. You're hitting the gross tumor with a higher Bailey dose right from the start. Might overcome repopulation better.
Makes sense. So for our T3N1 patient, over how many fractions and what are the dose levels?
Typically, it's delivered over 30 fractions, so 6 weeks total. The elective nodal volume, that big CTV covering potential microscopic disease, gets 45 gray total. That works out to 1.5 gray per fraction.
45G in 30 fractions for elective coverage.
Right.
Okay. What about the nodes we know are involved, the GTVN?
Those involved nodes get bumped up. They receive 50.4 gray total, which is 1.68 gray per fraction, a bit hotter dose for the gross nodal disease.
50.4 G for involved nodes, and the primary tumor, the GTVP.
That gets the highest dose. The GTVP receives 54 gray total, delivered as 1.8 gray per fraction. That highest dose is really aimed at maximizing local control where the bulk of the disease is.
54G to the primary, so 45, 50.4, and 54G, all delivered simultaneously in 1.5, 1.68, and 1.8 tree fractions over 30 treatments. That's the dose painting.
That's the RTOG 0529 ESSAB recipe. It's the blueprint.
Excellent. But hitting those targets is only half the battle. We need to protect the organs at risk. That secondary analysis of 0529 gave us some key small bowel constraints linked to lower GI toxicity. What are those numbers we absolutely need to aim for?
Ah, yes, the small bowel constraints. Super important for keeping patients out of trouble with diarrhea. These really guide the optimization. The key ones to remember are dose volume constraints. V25, the volume getting 25 gray, should be less than 185 cc. V30, volume getting 30 gray, less than 155 cc.
Okay, 185 and 155 for V25 and V30. Then it tightens up.
Right. V35, volume getting 35 gray, needs to be less than 40 cc, and V40, volume getting 40 gray, should be less than 30 cc.
Wow, less than 40 cc for V35 and less than 30 cc for V40. Those are pretty strict at the higher dose levels.
They are. And meeting them, or getting as close as possible while covering your targets, is a major reason why IMRT dramatically reduced that severe GI toxicity compared to 3D. You plug these into your planning system, and it works to respect them. It's often a balancing act during optimization.
Got it. Those are critical numbers to keep in mind. Okay, let's shift gears now to navigating some special populations and common clinical challenges. Back to our case patient. The 48-year-old man, T3N1, but he's HIV positive, well-controlled on heart, CD4 is 350. How does the HIV factor in?
Great question. Very common scenario. Because he's on heart, and crucially, his CD4 count is robust, greater than 200, and his is 350. The approach is generally straightforward.
Treat him like anyone else.
Pretty much. He should receive the standard chemoradiation regimen, 5-FU and mitomycin C, full dose, curative intent. With modern heart, patients with well-controlled HIV often have immune function that allows them to tolerate standard therapy quite well. We don't want to undertreat them based just on the HIV diagnosis if their immune status is good.
That's a key point, treat based on immune status, not just the diagnosis. But what if? What if his CD4 count was low, say under 200? How does that change things?
Okay, that's the critical pivot point. If the CD4 count were less than 200, that patient is definitely at higher risk for severe hematologic toxicity, especially from the mitomycin C, which can be tough on the bone marrow.
So you'd worry about severe neutropenia infections.
Exactly. In that situation, you absolutely have to discuss modifying the chemotherapy. The standard options are usually either using only one cycle of mitomycin C instead of two, or sometimes substituting cisplatin for the mitomycin C altogether.
Cisplatin being maybe a bit less myelosuppressive.
Generally, yes. It has its own toxicities, of course, but often less severe hematologic toxicity compared to mitomycin in this setting. It's about tailoring the systemic therapy to the patient's specific risk profile, still aiming for cure, but carefully managing the risks. Requires close monitoring, good supportive care.
Excellent. Clear framework for HIV patients. Now, what about patients with inherently high-risk disease, even with good chemotherapy, some just do poorly? Who falls into that category? And what does the data tell us?
Yeah, unfortunately, even with our best standard treatment, there's a group with a really tough prognosis. The secondary analysis of RTOG 9811 really highlighted this. It's the patients with T4N positive disease.
So, large primary tumor invading other organs plus positive nodes.
Correct. For that specific group, the 5-year locoregional failure rate after chemort was incredibly high. 60%.
60%? Wow, that's sobering. A majority recurring locally or regionally?
It is 60% failure rate. It tells us that for this very high-risk subset, our standard 54 gray might just not be enough dose.
And that provides the rationale for.
Exactly. That provides the strong rationale for ongoing dose escalation trials. Studies like the European Plato ACTV are exploring, if carefully pushing the radiation dose higher, maybe to 59.4 gray or even more, specifically in these T4N positive patients, can improve those dismal locoregional control rates.
Without causing unacceptable toxicity, presumably.
That's the challenge, of course, balancing efficacy and toxicity. But a 60% failure rate demands that we try something more aggressive for these patients.
Absolutely. Okay, another common clinical scenario. Recurrence or persistent disease after treatment. There's a famous pearl here. Remember to wait. Why is patience so critical?
The wait-and-see pearl. It's absolutely vital. And it comes directly from the ACT2 trial data. That study showed that complete response rates continue to improve for a surprisingly long time after treatment finishes, up to 26 weeks, or about 6 months.
6 months. So what looks like residual disease right after treatment might just melt away over time.
Exactly. It could be scar tissue, inflammation, slowly resolving tumor. If you biopsy a stable residual mass too early, say at 3 months, you might get a false positive, leading to unnecessary anxiety and potentially a major salvage surgery that wasn't needed.
So the hard rule is, do not biopsy a stable residual mass before 26 weeks post-treatment.
That's the rule. Obviously, if something is clearly growing or new symptoms appear, investigate sooner. But for stable findings, give it time. Patience is key.
Okay, but what if you wait the 6 months, do a biopsy, and it does confirm true local recurrence? What's the standard salvage approach then?
If you have biopsy-proven local recurrence at 6 months or later, the standard salvage treatment is an abdominoperineal resection, or APR.
Which is a major surgery, permanent colostomy.
It is. It's a morbid procedure, no doubt about it. Big impact on quality of life. And this is crucial, it offers a real chance of cure. The 5-year overall survival after salvage APR for local recurrence is around 50 to 60%.
50 to 60% cure rate after recurrence is actually pretty significant.
It really is. For a patient facing recurrent cancer after full-dose chemoradiation, it's a very meaningful chance at long-term survival. Patient selection is important, needs to be a resectable disease, but it's the standard salvage approach.
Good to know. Finally, let's touch on proactive toxicity management. Even with IMRT, patients get side effects.
Oh.
What are your go-to practical tips for managing things like dermatitis and diarrhea?
Right, gotta be proactive. For dermatitis, especially in the perineum and groin, daily sitz baths are great. Keep it clean, soothe the skin. Then pat dry gently and apply a thick moisturizer barrier cream liberally, something like Aquaphor. Loose cotton clothing helps too.
And if it breaks down, gets to that really painful moist desquamation stage.
Yeah, that's tougher. For severe moist desquamation, we often recommend a mix. Lidocaine for pain relief, combined with a zinc oxide-based cream fincdesitin, the diaper rash stuff. It provides anesthetic and a really good barrier to promote healing. Apply it frequently, sometimes need oral pain meds too.
Lidocaine plus zinc oxide, good tip. What about diarrhea? That's almost universal.
Yep. For diarrhea, start with diet. Low-residue diet is key. Limit fiber, avoid irritants, and crucially, scheduled loperamide, Imodium. Don't wait for it to get bad. Tell patients to take it regularly, say every 4-6 hours, to prevent severe diarrhea rather than just chasing it.
Scheduled loperamide, not just PRN.
Much more effective that way. If that's not enough, you can escalate to Lomotil or even consider octreotide in severe cases, maybe with a GI consult. But proactive management is key.
Excellent. Really practical advice there. Okay, let's distill this down into some high-yield clinical pearls for practice and boards. What's pearl number 1 regarding technique?
Pearl 1. IMRT is the standard technique for anal cancer, period. Based on RTOG 0529, it significantly reduces severe toxicity without compromising control. Don't accept 3D CRT as routine.
Got it. And for planning that IMRT?
Pearl 2. Always use a dose painting approach following the RTOG 0529 SEEB schema. Stick to those dose tiers. 45G elective, 50.4 Gary involved nodes, 54 Gary row primary, all in 30 fractions.
Okay. Pearl for HIV-positive patients.
Pearl 3. Treat HIV-positive patients with curative intent, but always check that CD4 count. Consider modifying chemo if the CD4 count is low 200 to manage hematologic toxicity risk.
Tailor the therapy.
And the Pearl for recurrence management. Pearl 4. For stable residual disease, wait and see for up to 26 weeks before biopsy. If true local recurrence is confirmed, salvage APR offers a 50-60% chance of long-term survival.
Perfect. And you mentioned a mnemonic for those tricky small bowel constraints. V25, 185, V30, 155, V35, 40, V40, 30. How can we remember those?
Yeah, try this. Think VSBS decline for the 40-30 rule. VSBS for volume small bowel safety, the volumes decline. 185, 155, then a big drop to 40, 30. So 185, 155, 40, 30.
185, 155, 40, 30. Got it. Helps lock those in. All right, ready for a quick board flicks. Test or recall?
Let's do it. Fire away.
Question 1. In RTOG 0529, what was the approximate rate of grade 3 or higher GI toxicity with IMRT? A, 11%, B, 21%. C, 36%, D, 49%.
Okay, thinking back, the IMRT significantly reduced it from the 3D era. The 3D rate was 36%. IMRT brought it down to B, 21%.
That's correct. B, 21%. Key finding of 0529.
Yep.
Okay, your turn to ask one.
All right, question 2. You're planning IMRT for a T3N1 anal cancer per RTOG 0529. What's the correct dose and fractionation for the elective pelvic and inguinal nodes? A, 54G in 30 fractions. B, 50.4G in 28 fractions. C, 45G in 25 fractions. D, 45Ag in 30 fractions.
Okay, elective nodes. That's the lowest dose tier in the SEB plan. And the whole thing is 30 fractions for T3 and 1. So that has to be D, 45 gray in 30 fractions.
Exactly right. D, 45G in 30 fractions, which is 1.5 dV per fraction. Perfect.
All right, last question. Back to that high-risk group. Based on RTOG 9811 data, what's the approximate 5-year local regional failure rate for a T4 node-positive anal cancer after definitive chemorT? A, 20%, B, 40%, C, 60%, D, 80%.
The sobering statistic. T4N positive. That failure rate was alarmingly high. That's got to be C, 60%.
Again, C, 60%. Really underscores the need for better therapies or intensification for that group. Okay, great job on the blitz. So that wraps up our deep dive into IMRT, planning, and special considerations for anal cancer. We've covered a lot of ground today.
We really have. To quickly recap the main takeaways, first, IMRT is the standard technique, thanks to RTOG 0529, showing less toxicity, same cure.
Second, planning should always use that dose-painting SIB approach from the protocol. Stick to the recipe.
Third, HIV-positive patients get curative intent treatment, but check that CD4 count and be ready to modify chemo if it's low.
And fourth, for local recurrence, remember to wait 26 weeks for stable residual disease and know that salvage EPR offers a real chance, 50–60% of long-term survival, if recurrence is confirmed.
Absolutely. And maybe a final thought to leave our listeners with. Think about that ongoing challenge with the T4N positive patients. That 60% locoregional failure rate really drives home the need for continued research into dose escalation or finding other ways to intensify treatment for those at highest risk.
It really does. It highlights that constant effort in our field to push the boundaries, maximizing tumor control while always trying to minimize the burden on the patient. It's a delicate balance, and that's where the innovation continues.
Well said.
Complete practice oral boards at radongsmartlearn.com and subscribe to Radon Smart Review for our next session. Thanks for tuning in.